Okay, let us start with the case. This is a 29 plus 1 or 2 days, weeks, male infant. He is one of the quintuplets which was born in 2010. It was emergency LSCS, Abgas 6 and 7. Baby was transferred to NICU. I think Dr. Mithul was there when the babies were born, probably. Child was brought to NICU on TPC resuscitated. Birth weight was 920 grams. Child had severe hyaline membrane disease, was intubated, ventilated. First dose of surfactant was given earlier. Child remained on ventilator support for next 3-4 days. So this was the X-ray. And in view of hypotension, poor perfusion, he went through all that initial stabilization, like most of the preterms go. And subsequently he stabilized. And by next 36 hours or so, day 3, he was pretty stable. And then we could speak to the parents with confidence that we think that we are out of that storm. So the roller coaster journey for our baby started. Why I say roller coaster, I think you understand how difficult for these babies to go through those 6 to 8 weeks of journey, and what parents go through during that period at the same time. So one of the many challenges we see apart from the mortality, I think the morbidity associated with that. I think last 2-3 decades what we have been seeing is better survival with better kind of equipments, better kind of technology and better expertise what we have. But I think this time, we should look beyond survival. It's not just survival, but intact survival or the quality survival. That should be the goal. So what are the different challenges we face in management of these tiny preemie babies? One is insensible water losses. Again, the temperature issues they have. Almost all of them have ventilation issues. They can have bronchopulmonary dysplasia, apneas. Anemia is another issue. Electrolytes and metabolic disturbances along with that. And in the initial part, especially the first 7 days or so, what we face is the hemodynamic instability, or especially in the first 24 hours. And the infection, I think it is one of the curses what we face in the NICU, especially in this part of the world. And the daunting challenge is to keep with the nutrition, to keep pace with the nutrition in terms of calories and proteins, what these babies receive when they are inside the womb. I think that apart from that, sometimes we come across these problems, may not be with all preterm babies, but necrotizing enterocolitis and the surgical issues. So these are the conditions, they complicate our nutrition management or they increase our challenge. If these babies are not fed adequately, they are not supplemented with adequate calories and proteins, it will lead to poor weight gain. Not only that, it will reduce the number of neurons and the synapses which are formed in the critical period. The brain is in the development phase, and if in that phase the child doesn't receive adequate amount of proteins and calories and the essential amino acids and fatty acids, it will affect the neuronal growth, it will impair neurocognitive development and ultimately leading to impaired growth as well as development. Okay, so both the parameters will be severely affected. So that is the reason why nutrition is extremely important when it comes to extremely low birth weight infants. Now let me ask you, what fluid would you start on day 1? Or rather I will say, what fluid you start in practice on day 1? Is this 10% dextrose, 10% dextrose amino acid, or the third option, or you have got some other special concoction you start in a unit? Anybody, you can just say that to start. I think perfectly alright. I think that the perfect answer, 10% dextrose, amino acids, and if the child is hemodynamically stable, then we'll start some NG feeds, trophic feeds, that's what you meant. I think absolutely right. And if you're going to start amino acids, how much will start? Okay, I think you don't have to answer. I think we'll come to that when we come. So basically, when I say this, it should be three-pronged strategy when it comes to the nutrition. Or the goal should be something like to provide an uninterrupted flow of nutrients, okay, so that you maintain the anabolic state. That is very, very important. Anabolic state is very, very important for growth, okay. Then to stimulate and support the transition of immature gastrointestinal tract to mature state. And you start small amount because your gut is immature, but you help the gut to become mature over a period of time and you increase the feeds. So that is the second goal. And there has to be a smooth and gradual transition from total parenteral nutrition to total enteral nutrition. Actually, this is the three-pronged strategy, or these are the three goals we look upon when we manage this patient. So why it is important to maintain the anabolic state? Because it's very simple. Your supply and demand has to be maintained. Now your supply should be more than the demand for the energy expenditure, so that extra energy is stored or utilized for bodybuilding. Okay, if that doesn't happen, then you will lose weight or it will lead to extra uterine malnutrition. So I think we have to take care of that. We have to supply adequate calories and adequate proteins, which will take care of expenditure as well as the losses. So let us look at the energy balance. I think these are not absolute numbers. These are some figures, which I have got from the nutrition book. This is the BMR, or the basal metabolic rate or energy expenditure to maintain the BMR in the newborn babies, around 75 calories. Activity takes around 10 and the energy losses around 10. So our total energy expenditure will be around 110 to 120 calories per kilo per day, taking into account the energy cost of the growth. So this is your basic requirement. Okay. Now there is stress. Most of the babies are under stress. Either they have HMD or they have got PDA, they have got infection. And if that is there, then your stress related energy expenditure, if you calculate, if you add to that, then these are the requirements, around 120 to 150 calories per kilo per day. Now this is what you need to supplement to maintain the positive energy balance, positive nitrogen balance. So this is in short, okay, expenditure 120, in that BMR is 75, and we have to take into account the stress factors. If you give 10% dextrose alone as a nutrition or the fluid, how much will supply? Any idea? Alright, you are giving all the perfect answers. See, if you are giving, even if you give at 180 ml per kilo per day 10% dextrose, you are giving around 70 calories per kilo per day, just half of the requirement. Okay, so here you are energy deficient. Okay, so you are supplying inadequate calories. Not only that, you are causing fluid overload, then you are going to lead hyperglycemia, osmotic diuresis, proteins will be broken down, your lipids will be broken down, there will be essential fatty acid, amino acid deficiency and micronutrient deficiency. So 10% dextrose alone is extremely suboptimal. Okay. So the optimum nutrition, what is optimum nutrition then? So where the adequate proportions of glucose, proteins, fat, vitamins and minerals are given to the baby. So we should be aiming at optimum nutrition. How will you get there? I think you have to use total parenteral nutrition when optimal enteral nutrition is not possible. Now coming as a part of TPN, supply of glucose. I think this is extremely important because glucose is the sole energy source for the brain. So all the babies should have normal glucose levels, and even a single episode of hypoglycemia in preterm babies is going to be detrimental for the brain. Okay, and there are many studies published and proven that hypoglycemia is very, very dangerous. Okay, it shouldn't be ignored. And especially so in case of preterm babies, and in our population especially, our babies are not only preterm, they are even growth restricted. Okay, and that is the reason they are more prone for hypoglycemia. So don't ignore the risk of hypoglycemia and consequences associated. So your minimal glucose intake should be around 4 milligram per kilo per minute. That is your glucose infusion rate. And for protein synthesis, we require another 2 to 3 milligram per kilo per minute. So taking into account all that, our GIR should be around 6 to 8 milligram per kilo per minute. And these are the maximum values we give, around 12 to 13 or up to 15 milligram per kilo per minute for the preterm babies. So these are the optimal levels to maintain, and glucose intake should be such that of total caloric intake, they should form around 60 to 70% of that. Okay, this should be the composition. Alright, because if there is excess glucose administration, what will happen? It will get converted into fat, which is not good, and not only that, it is not energy efficient as compared to lipids. So there will be more CO2 production, and these babies may get stuck on the ventilator if you are giving too much of glucose. We don't see that much this problem in the newborns because we are always calorie deficient, but in the pediatric intensive care unit, if the child is receiving TPN for prolonged period for some reason, and if you are not careful enough to see that you are not giving excessive glucose, they will be ventilator dependent because more CO2 production. Okay, so one should keep that in mind when you are giving glucose. Now coming to next is the fat. Why fat is important in the parental nutrition? Because if you are most of the lipid accretion happens in the 12th trimester, or same as protein, and our babies are born, or the preterm babies are born in the 2nd trimester. So this accretion doesn't happen. So the lipid stores are very, very less or minimum. So what will happen? Those lipids will be oxidized and leading to essential fatty acid deficiency. And as we all know, essential fatty acids are important for the growth of brain and the retina. And when you have this essential fatty acid development, we are definitely going to have some neurodevelopmental abnormality. How will you give them? They should at least constitute 30 to 40% of total energy intake. So what we said, glucose should make at least 60 to 70, fat should make around 30 to 40. So if you say 60% glucose, 30% fat, the remaining 10% will be protein. So this should be your distribution of calories when it comes to the babies. We normally start around 1 gram per kilo per day of lipids on day 1, and then we go up to 3 grams per kilo per day, and what is available in the market is SMOF lipids right now. Even we have got intralipids, so any of which is available you should be using. What are the issues associated with lipid supplementation? One is hyperlipemia. So one should be careful about that, because if you give lipids, the babies have limited stores or levels of lipase, and therefore they can't break down, and what will happen is it will lead to high levels, and that's why you need to do the triglyceride levels in these babies and then monitor them closely. If they are above 200, then probably we'll have to come down on the lipid supplementation. It should be infused over 24 hours. We used to do that, over 8 hours, but again, it will lead to hyperlipemia. So that is the reason we prolong the lipid supplementation. So we, along with glucose, along with the proteins, the lipids are usually given at least 18 hours or preferably over 24 hours. Now there is a couple of myths, which we should address. One is lipids shouldn't be used in pulmonary diseases, especially with pulmonary hypertension. And the other one is it will increase the risk of hyperbilirubinemia, sepsis, and it can induce thrombocytopenia. Again, there are a lot of literature saying that this lipids per se don't cause sepsis. It's us. We give sepsis to the baby if the lipids are not prepared aseptically, and that's why one should make a habit that all these drug preparations, all the IV fluid preparations should be done under strict aseptic precautions and should be done by the nurses trained in that, and at least 2 nurses should be there. One nurse can't do this. Okay, there are 2 people are needed, and it should be done taking all aseptic precautions. If you have laminar flow, well and good, it is the best way to go ahead. If you don't have, it doesn't stop you. And for that I give you one example. You must be knowing Dr. Prem Sheth. I think she was teacher for the most senior people here, and I started my neonatal career with her, and I was at Bombay Hospital. I worked there for 6 months. There was no laminar flow, and she used to look after smallest babies. They used to put PICC line once in a while. In those 6 months, I didn't see a single blood culture proven sepsis in that unit. There was no laminar flow. And till now, I can't do that in my own unit where I practice. We have got laminar flow, we have got 1-to-1 nursing. Still, it is not possible. I think hats off to that teacher, the way she used to teach her nurses. And I used to watch in the night, 4 o'clock, 2 nurses will do the TPN preparation, and they used to do total parental nutrition that time, in 2000. And not a single sepsis, blood culture proven sepsis in the unit for 6 months. That was amazing. So I think the myth is that, the lipids induce sepsis or the TPN causes sepsis. It's a myth. And I was going to say bullshit. I think yes. I think it's a bullshit. I think one shouldn't buy that. Try to get, if you do it properly, TPN doesn't cause sepsis. And definitely hyperbilirubinemia and pulmonary hypertension. I think there is some evidence or the literature to support that if there is pulmonary hypertension, avoid lipids. Or if you are giving full dose, that is 3 grams per kilo per day, maybe you can come down to 1 gram per kilo per day. Okay, because sometimes the lipids they line across the pulmonary vasculature and may increase the resistance. So that is the theory behind it. Okay, so lipid supplementation should start on day 1. You should provide around 30% of the non-protein calories. Maximum lipid dose around 3 grams per kilo per day, and should be given over continuous infusion over 24 hours. And serum triglyceride level we should try to maintain below 200 milligram deciliter. So this is the I think a recommendation by NNF. It is the recommendation by Espergan as well. Now coming to amino acids. Again, the fetal accretion of the amino acids and the proteins happen in the 2nd and 3rd trimester. So if not supplemented early after the birth, then every day the babies lose around 1 gram per kilo per day of protein. Okay, and if this small baby loses this much of protein, definitely is going to cause a lot of protein malnutrition, and along with that essential amino acid deficiency. Okay, and how are we going to do that? So we are going to supplement amino acids. At the same time, don't forget to supplement adequate amount of calories, because to use 1 gram of protein, you need 30 non-protein calories. So if this 1 gram of protein going to go into as a building block, so you need 30 non-protein calories. So if you are going to give 3 gram per kilo proteins, you need to give at least 90 non-protein calories to supplement that. Okay, so don't forget this. Or there is another ratio, 1:6 protein to non-protein calorie. Okay, that you should be maintaining. So amino acid supplementation should start on day 1. Rather, it should be started in first hour of life once you start IV fluids. Minimum dose may be 1 to 1.5 gram per kilo per day, and you can go up to 4 grams per kilo per day. And it can be done gradually. And there's a school of thought that even very aggressive parental nutrition, they're starting amino acids at 3 to 4 grams per kilo per day on day 1 and 2 to 3 grams of lipids on day 1. The outcomes are better, but I don't know, I'm not sure about that. There are some complications associated with that. So we follow a middle path where we start amino acids and lipids on day 1, and we gradually by day 3, day 4 we are on full TPN. Vitamins, unfortunately we don't have vitamins, pediatric vitamin preparations in India. They come in, go out, for a brief period. So right now we are using adult vitamin preparations, and the dosages are something like 0.25 to 0.5 ml per kilo, and that's what we add. When you add vitamins, make sure that you are using that foil, so that they are protected from the sunlight, because they get converted into peroxides, which may be harmful to the brain. Minerals, this we can add sodium, potassium, chloride. Take care of calcium, phosphorus along with that. So all these can be easily added and given. Trace elements, again the same story. We don't have the trace elements. Again they come into the market and vanish immediately after that, before you start using. because they are important. The deficiency can lead to various problems. Zinc you can start from day 1, okay, but the rest of the things you can wait for 2 weeks. So if you in the West, that's how they start. All the trace elements are added. After 2 weeks, they come as already ready-made preparations. They come into the unit, and you have to just hook up to the baby. Your ideal TPN will be something like adequate proportion of glucose, proteins, fats, and minerals and vitamins. And this is the composition. I don't know which protocol you use for the fluid in a unit, but this is again I've taken from one of the books. We are a little bit more conservative. We use around 80 for babies less than 1 kilos, and again 80 for between 1 to 1.5 and more than 1.560. But I think this is a rough guideline. Maximum you can go up to 200 or 160 200 ml per kilo per day. But as a rule, in our unit we restrict total fluid intake to 150 ml per kilo per day in the first week. That is, and we have seen that it reduces our incidence of BPD. It has reduced our incidence of PDA in the unit. So over the 5 years we have learned. Initially we used to give 180 to 200 in the first week, but last 2-3 years, we have been restricting to 150 ml per kilo per day. What is monitoring during TPN? I think clinical monitoring is very, very important. So you have to monitor clinically. I think I can't emphasize more. Look for the phlebitis if you are using peripheral IV cannula for that, and you can monitor all liver function tests,
so hypoglycemia
tests, and this is the laminar flow, how the 2 nurses are preparing, in completely aseptic environment. And don't forget to monitor the growth of the baby. I think it is extremely important. So you should be charting and see that if the baby this baby started here, then lost weight, and then started gaining weight. So it took almost 2.5 to 3 weeks to reach birth weight. And we try to achieve birth weight by 2 weeks. And sometimes we falter and we end up, reaching birth weight by 3 weeks. But still it is not bad. But I think our aim should be that, the baby reaches or crosses birth weight by 2 weeks. And then it should follow the trajectory. Weight gain should be around 50 to 20 grams per day. The length around 1 centimeter a week, and the head circumference around 0.75 per week. Again, the regaining birth weight earlier is the first step. And as I said, I think one should look at that, how early the baby catches up with the birth weight. So this baby on day 4 or something, I think we were on day 2, day 3, about 100 ml per kilo per day. We started Amino when we increased over next 2 to 3 days. We started trophic feeds on day 3, and child was extubated to nasal prongs on day 4. Now, why trophic feeds? Why trophic feeds are important? Once the baby is hemodynamically stable, does it have any advantage? Okay, are there any contraindications? So the trophic feeds are nothing but they are small volume feeds. I think you are aware of that. Physiologically, there is a rationale. It helps in gut maturation, and in practice, it has shown that it reduces time to full enteral feeds. It helps in faster weight gain. It reduces the incidence of feed intolerance, less NEC and less hospitalization, and these are the proven benefits. Okay, there's a physiological rationale. At the same time, it is supported by the practical evidence. Early versus late feeding, again the same story. You start early, you can discharge early. Okay, if gut is ready, use it. So there is a saying that, use it or lose it. Okay, the same thing applies. It is basically we use it in this saying in the PICU and adult ICU. Same applies in the NICU as well. If gut is available, please use it. Don't ignore it. Okay, but you have to take into consideration all these factors where sometimes you'll have to go slow. So this child on day 5 was TFI 140 ml per kilo per day, full TPN. Child was doing well, spontaneously breathing, and we were still on trophic feeds on day 4. Probably that was because of patent ductus artery. So the child has a big duct, so we were a little bit cautious to increase the feeds further. And subsequently child had PICC line, all the umbilical lines were removed, and we moved ahead. So this was the reason why the child had restricted TFI, but we ensured that child remains on full TPN during that. And as I said, every PDA need not be treated. So when it comes to feeding, you should take into account PDA along with that bronchopulmonary dysplasia, your GR, if there is persistent pulmonary hypertension of newborn, and if there is any associated congenital heart defect. And more babies we see in our, especially in the pediatric ICU and cardiac ICU, the babies who have faltered growth after cardiac surgery. They come in a bad shape. When they come to us, they are already malnourished, they have infection, they have got complex congenital heart defect, they undergo surgery, most of the times it is emergency surgeries, and they take long time to recover. And I'm not sure that nutrition is important with us as well as in the small babies. I think let them distribute the tea. I think I was going to say something. Let's carry on. Let them give. What I was going to say that I don't know, somebody, many of or somebody can help me here. I think there must be a way to measure nitrogen balance. Okay, so I'm in talks with the dietitian just to see the positive nitrogen balance, how it can impact the outcomes, especially the babies or the newborns and infants who undergo cardiac surgery. Because many of the babies who come to us, they were extremely malnourished, infected, septic, and they undergo surgery, and they never, at least forget first 4 or 5 days, they never reach full feeds, sometimes in 2 to 3 weeks time, and already they are lagging behind so much, and then almost 3 to 4 weeks of inadequate supply. I think they universally do very bad. So I think that's what whether the positive nitrogen balance before they go to surgery probably might help in their faster recovery. So in our case, we started feeds, then gradually increased over a period of time, and by day 27, the child was receiving 2/3 of feeds and 1/3 IV fluids. We started fortification. And how many of you use fortification in the unit? Okay. So others they don't use because they don't have access or they don't get it. I think the fortification does good. Okay, and there is again good amount of evidence to support that. So it can help in basically building it doesn't give too much of calories, but it definitely helps in protein and calcium phosphorus supplementation. How many of you use bolus feeding? Rather, I will ask like that. How many of you use continuous feeds as a replacement of bolus feeds? Okay, so I think the bolus feeds are always better because they are more physiological, and the intermittent or the continuous feeds have their own complications and have own limitations. So always preferably use bolus feeds unless you are stuck with the child who doesn't tolerate. Fortification, I think there is ample evidence. I am not going to talk about that. And along with that, you can use MCT oil to supplement the calories. So this is some of the Cochrane evidence. With fortification, there is good weight gain, there is good increase in the length, and even the head growth. So all positive things with fortification. So please use it if it is available. So we did pretty good. By day 22, we were on full feeds in this child. We started iron supplements, and along with non-need-to-do sucking, we started kangaroo mother care. I think again, I can't emphasize more on kangaroo mother care. Whenever possible, if the child is hemodynamically stable, even if on CPAP, you can try kangaroo mother care, and it is pretty safe and one of the most beneficial practices, to be implemented in the NICU. Palada. Okay. All right. So the child did pretty well in the long run. Head ultrasounds were normal, and subsequently child was discharged. So these were the challenges we faced when the child was in the ICU. But I think we still pretty well managed the nutrition part. I'm not sure about this, but at the nutrition part we could manage well, and child went home ultimately. Okay, so this is what we recommend. Nutrition requirements 120 to 150 calories. Please remember this. If you are not giving enough calories, you are going to be a cause of extrauterine malnutrition. So if you don't want to be responsible for that, please supplement adequate calories and proteins. Make sure there is adequate composition and proper ratio of glucose, proteins and fat. There has to be individualized nutrition plan for each baby, so taking into consideration the risk factors and the limitations associated with that. These babies should be closely monitored. Start minimal enteral feeds the moment the gut is available to use. Okay, so don't ignore that. And of course, kangaroo mother care. And always, breast milk is the best milk. Okay, try to use it whenever it is available, and there has to be a gradual transition from TPN to TEN. Thank you very much.